about challenges implementing and delivering integrated care.
Yeah.
Okay,
Thanks
good luck.
Okay, good morning everybody. Thank you very much for coming along. My name is Sarah Barry. I'm from Trinity College Dublin and I will be presenting this morning with PJ Hartnett, who is from the Integrated Care Programme for Older Persons in Ireland. And just to say that we both have wonderful teams behind us, PJ with the Health Service Executive and me in the Centre for Health Policy and Management in Trinity College Dublin. So we're going to do a sort of a two-hander here. I'm going to speak a little bit about the policy context for a moment in Ireland and how we're aiming to have a systemic or systems-based approach to integrated care. And that's under the auspices of a drive towards universal health care in Ireland. PJ is going to talk about the lessons that are being learned in practice with the Integrated Care Programme for Older Persons. I'm going to briefly present some findings from a case study work that we have done in collaboration and co-designed with the ICPOC programme, and then we're going to just pull out some conclusions. So just briefly, the policy context in Ireland, just to give you a little bit of background. So some of you may have heard, but in Ireland we have an all-party initiative currently underway to transform Irish health and social care services, and it's with the intention of turning Ireland much more towards a universal healthcare system, which it currently is not. And there's a couple of approaches that are outlined in that, if you like, government report, or Oireachtas. Oireachtas is our Houses of Government report, and that is to set out a population health approach to how we are delivering on a universal healthcare agenda. That will involve expanding entitlements, creating a proper kind of funding framework that will offer better security, and obviously then confident implementation of this very broad programme of change. But at the heart of it is a service delivery model of integrated care. Now, the approach of Sláintecare, which means health care, your health, is to take a very whole of systems approach. So in Sláintecare, it means integrated care means system strengthening. So some of the kind of things that other speakers have spoken around, creating the right kind of conditions that will deliver integrated care. The service coordination piece is the piece that I suppose we've done the most work on, and PJ will be talking a little bit about in a moment, and then very much leaning that shift left to that network building and that community integration that some people have already spoke about this morning. And then finally in 2019 we have some concrete implementation actions around the delivery of integrated care taking place. These include an integration fund. I was just mentioning to PJ when I heard Anne speaking about 300 million. We look very poor. We have a long way to go. But anyway, we have a start and we're doing something to test and scale new models of care. There's a focus on integrated workforce planning, getting the right information architecture and standards in place, and then the creation of a little bit like the LINs, the Regional Integrated Care Organisations, or RECOs. So we have quite a challenge around the geographical and the organisational alignment. So I'm going to hand over to PJ, who's going to give you a bit more the meat on the bones from the ICPOC perspective.
Thanks, Sarah. Yeah, it's always with great envy that we look across the water at Scotland and look at the work that they're doing. So we've learned a lot and benefited, I think, from the work that Anne and her colleagues have done. I'm going to talk briefly about the implementation aspect of the work that we've been doing, and it's been great to partner with Trinity and Sarah and her team in terms of understanding, getting insights into the process of implementation and what that looks like from the point of view of the people who are tasked with implementation. We have a website, icpop.org, which contains a lot of material, videos, presentations, and in December 2018 we launched Lessons Learned, which was an insight into 2 years of implementation with sites who are seeking to develop integrated care for older persons. We currently have 13 sites across Ireland who are working on on this. We've grown from 6 in 2016 to 13 last year, with 8 or 10 new sites in the pipeline. And it's a way of working that appeals to people. And it involves many of the ingredients that are familiar to people who are working on integrated care internationally. So it involves the deployment of case management, it involves new ways of working for people in terms of community roles, working at the top of their licence, it involves the development of new pathways and age-tuning the service. And so some of the impacts that have been delivered over the last 18 months to 2 years are available within that early stage insights report. Our team, it's a very small team, its primary purpose really is to work with local clinical managerial leaders in terms of using a 10-step framework to develop care pathways and implement new ways of working, etc. I'm not going to go through all of the detail of that, but a lot of the messy reality of implementation involves working with people at the coalface and addressing many of the issues that you heard about from the Canadian example, whereby the lived reality of changing the way people work is often an incredibly difficult struggle for everybody to address. So typically our involvement lasts about 18 months when we are seeking to work with local leaders on this process. This is a slide that depicts one of our sites, which in terms of McDonald's, the fast food outlet, has a term, leading edge operator. So this is one of our leading edge operators, one of our 13 sites. The kind of change that they've delivered speaks to both a cultural change, experience of care, value in terms of efficiencies and so on and so forth. 2 years ago, this particular site struggled to recruit registrars. Last week, they interviewed 34 registrars for 3 posts. For every euro we've invested in this site, there's been a return of investment of around €7. The bed days saved have been significant. The alignment of previously disconnected services in the region, which were orphan services, often standalone, bringing them into an overall ecosystem of care has been incredible. When you look at the issues around access for older people seeking to access healthcare in Ireland, one of the really big problems we have is that older people default to emergency departments in order to get the care they need, and that's not what we want, and that's certainly not what older people want. The number of people who default to an emergency department who are over 75 in this area is about 5%, and that compares with about 20% typically in other areas. So what we're seeking to do is to take some of the insights from this site and from other sites and scale that up. So in 2014, the number of areas around Ireland which had age-attuned pathways, which were working on the issue of addressing bespoke pathways for older people, was actually diminishing. The number of people working in specialist roles were diminishing, and the actual energy and effort and enterprise associated with developing pathways was actually on the decline. And at the end of last year, when we looked at the number of places that were working on one or more aspects of age-attuned pathways, it started to demonstrate that this kind of work has really caught people's imagination nationally. So when we looked at the insights around the work that I've just described, we were very interested in some of the kind of things that Scotland had to say. The idea that you put the citizen first, which was kind of emerging out of the Christie Commission in Scotland, rebooting public services to think about their fundamental purpose and reason for being. The needing to describe what it is exactly that we're seeking to scale up and what measures are appropriate that are associated with the kind of functional gains that older people want, as opposed to the organisational gains that are often a kind of political focus. So in our report, we've made some suggestions about what route to scale, the kind of methodology associated with scaling in terms of complex adaptive system as a kind of context for the change, and how all of that might be incentivised. And we've got a benign policy context now that we didn't have before. And these are some of the insights that are reflective of the kind of implementation science literature that we're reading, which is that methodology really does matter. The way you approach a change is fundamentally important. The command and control approach is not really one that's appropriate for a complex system where you have high autonomy actors who can decide whether or not to engage. Like politics, all integration is local. Everybody needs to feel that their version of integrated care really is something that is unique to their particular area. The timeline between expectations and improvement is also something that has to be carefully managed, because there are often emergent and iterative and unanticipated benefits and initiatives that emerge. A foundational aspect of what we do is around local governance. Whilst we have an integrated health and social care system in Ireland, very often people are held accountable for institutional performance as opposed to the needs of the population. So establishing local governance and getting them to focus on populations as opposed to institutional priorities is a real key to some of the work that's been done. And the other final point on this is that people really do know what it is that they want to achieve. They get it, they understand, they have a vision, but they often don't have the means to realise that ambition and vision. So a relatively small amount of money tends to be sufficient for them to be able to reorganise what they do, provided you give them the autonomy to be able to do so. Sarah.
Thanks, PJ. So as part of our work with the Integrated Care Programme for Older Persons, we conducted a case study of 3 of the pioneer sites, and I just want to give a shout out here for Maeve Nia-Loon, who is our researcher who worked, if you like, on the participant observation and rendering the text of this research. So we have a couple of, I suppose, key findings that came out of that work, which was conducted over quite a number of months in 2018. And that is that the multidisciplinary team is absolutely fundamental as a mechanism of integrated care delivery, both in terms of the team members who are driving the changes, their ownership of the, if you like, the vision, but also in terms of challenging the status quo of the way things are done and shifting those professional boundaries, which they can be quite a challenge in trying to do things differently. The multidisciplinary team progress can definitely be constrained by systemic or organisational factors, as PJ has mentioned, and he's highlighted the importance of that person-centred approach, if you like, first. Nonetheless, I think there is an argument for thinking about the tipping point. It's well known in change management literature that if early adopters don't begin to find, if you like, the conditions and a system that's, if you like, able to move with them in due course, then they become fatigued and disillusioned, and no real change happens. So I think one of our big questions around scaling is how do we start to overcome the fragmented funding structures, the lacks of multi-annual funding. There's quite an issue with the turnover of senior decision makers, and therefore, if you like, that not only the kind of political cover, but also the organisational policy perspective, the strategic direction. How do you get continuity there? And then obviously a range of complex professional contractual negotiations. And then with the Integrated Care Programme for Older Persons, we've basically coming to the conclusion that this this really does have the potential to be a new approach to health system reform, at least in the Irish context, which generally health system reform has been very understood as, rearranging the structures and changing things, whereas the integrated care approach is very much bottom-up driven. So embracing the complexity, as PJ mentioned, really highlighting context and working across the community. So I think the general message here is that we're finding from our case study is that the contextual factors are critical, not only at local, which PJ has pointed out, but also at programme and system levels. Now this slide, just briefly put it up here for a second. This was part of our case study work. Was we did a survey with all the participants in the ICPOC programme, and I just want to highlight, this is data, rich data that I'm currently writing on and delving into in more detail. But what I do just want to highlight here is that we have two issues there. We've got a number of responses. And you can see that the big issues here that people were talking about a lot were cultural and organisational in terms of a balance against some other issues. And these were both weighted, if you like, as a sort of strongly or a moderatively negative impact on progress to implementation. And I think we need to sort of drill into this and understand a little bit more in detail, but it does highlight how important context is in driving change. So some of our findings from the case study in general, as I've just said, context matters as a bottom-up driver of implementation. And the multidisciplinary team both characterises and drives implementation, and that to some extent can be a double-edged sword with both sometimes positives, sometimes negatives there. The challenge of generating community leadership in a fragmented public-private mixed system as in Ireland. So one of our big challenges is we've got a very complicated mix of public and private provision with a lot of perverse incentives. This is something we're going to have to overcome to really implement integrated care. The importance of a population mainstreaming approach for implementation at scale, which I think one or two other speakers have highlighted very clearly. And then obviously, how do we get that right balance of ownership and innovation? So in other words, capturing all the good of the local whilst also scaling to the global. And then there are a lot of positive that come from a lot of positives from focusing on understanding and working with the complexity, with the local context, and with the community. So, in conclusion, we have a couple of points from both of our perspectives. Will I just fire ahead with them? Yeah, and PJ, I'll give you a minute if you want to say anything more. But basically, to sum up, implementation methodology is absolutely critical, and somehow that methodology has to be able to do what we call the down and dirty. The multidisciplinary team can be an antidote, and excuse me, a powerful antidote to the system fragmentation that we have experienced in Ireland, but that is a very long journey, I think, and those teams are going to need serious resourcing and support. The policy context is fundamental, and I just highlight there that we really need to be clear on the theory of system change that we are assuming or that we have working behind. And we all know that the operational cycle and the policy cycle turn at different paces. Users as an asset in co-production, and this is really, really important that we bring the clients, the patients, the carers, all these people on board in terms of making the change that we need. Finance, as we know, needs to be dynamic. It's absolutely critical. I'll let PJ make his point on ICT here because he's down and dirty with that one, most definitely. And from my perspective, I think from a policy analysis perspective, ICPOC potentially offers a model of bottom-up, top-down dynamic of system reform by focusing on patients' needs first. So, if you like, integrated care in the universal healthcare perspective, which is where Ireland is at from a policy view, is what it looks like on the ground, and it has great offers to lesson on how to deliver in practice. And I'll just let PJ say a word on ICT. You're fine. Okay, great. We'll finish at that, and thank you very much for listening.
Thank you so much, PJ and Sarah. Are there questions? No? Thank you very much. Thank you so much. Wonderful. Oh, there's a question.
Gracias. Sí, muchas gracias y felicidades por la presentación que han hecho. Yo tengo dos dudas, dos preguntas que me gustaría que me contestaran. La primera es si y cómo valoran la dimensión de las residencias y su ubicación, por un lado. Y segunda pregunta sería, ¿hasta cuándo están ustedes, en qué porcentaje tienen implantado el sistema de libre de ataduras? Gracias.
Is there somebody here who can translate this? Oh, you have understand?
Yo hablo español, pero no entendí todas las preguntas. Por favor, ¿me puede dar muy concisamente para que pueda entender un poco mejor?
Sí, me refiero a ver cómo valoran y en qué dimensión tienen el concepto de la dimensión de las residencias. Pueden ser muy grandes, pueden ser muy pequeñas, muy medianas. ¿Qué tipo de residencia es la que considera usted la más adecuada, no solo por su dimensión, sino por su ubicación? Y la segunda pregunta era, hay un sistema de libre de ataduras, que las ataduras a los residentes pues pueden ser químicas o pueden ser...
Bueno,
está claro, ¿no?
A ver si entiendo. Ataduras no estoy segura qué es, pero tal vez alguien me puede traducir. La primera, por Irlanda, lo que estamos trabajando, si he entendido bien, son poblaciones de 50.000 personas. Ahora, el ICPOP, el programa en que PJ está involucrado, son proyectos pilotos de quizás poblaciones. What size are the populations of the projects that you work with?
Each of them typically 100,000.
Más o menos el proyecto en que está trabajando él son 100.000 personas por proyecto, pero tienen una manera de trabajar que está enfocado en la gente con necesidades complejos. It's the complex care needs, isn't it, that you focus on? So the complex care needs. La segunda pregunta, perdona que no entendí la palabra exacta. Si alguien me puede dar una traducción, puedo responder. Si no, hablamos afuera del auditorio y tal vez nos podemos entender un poco mejor. Gracias.
Can you summarize a little bit for the non-Spanish audience?
Okay. Sorry. So just been asked to just translate that a little bit. I think the question, and I may have misunderstood, so I'm sorry. Also, the sound is not great here on the stage. But I think the question was, what size populations are we working with in our units of organisation? So they're community health networks of 50,000, and then PJ through the integrated care programme, the pilot projects are with populations of about 100,000 persons, but they do take a focused approach around the people with most complex needs. And I think that for that reason, the referral process is very important, very critical. But that's really PJ's bailiwick. And then the second question, I'm afraid I was missing one key word to be able to understand well, so apologies for that. But the Senor and I hopefully can have a chat outside and we can clarify a little bit more. Thanks very much.